To be or not to be, that is the question, is first line of arguably the most famous speech in Shakespeare's Hamlet. But in my work as an endoscopist, we face a similar dilemma, which is to band or not to band, and that is the question. So let's explore together the considerations to use endoscopic band ligation in the management of varices. The focus will not be on assessing the efficacy of the band ligation technique itself, but rather on identifying the appropriate locations where band ligation can be applied safely and effectively. I remember when I first started performing endoscopic band ligation for esophageal varices many years back, and my mentors emphasized the importance of banding close to the gastroesophageal junction. This made me wonder why. Why is it the preferred site? And is it okay to band anywhere in the esophagus or stomach? As you can see here, you may find varices in the cardiofundal area, along the lesser curvature of the stomach, in the distal esophagus, or in the proximal esophagus. So what are your thoughts on this? Can you apply band ligation to all these locations? Or is there specific areas to avoid, and if so, where and why? Let's agree that we aim safe and effective endoscopic band ligation. So we should target the areas where the veins are superficial, or in other words, at the mucosal level. Please excuse my drawing skills, they might not be perfect, but I hope they serve the topic understanding. These are the esophageal wall layers, and these layers, as you can see here, from the innermost to the outermost, include the epithelial layer presented in pale pink as the esophageal epithelium, and a darker shade for the stomach epithelium, followed by the lamina propria presented in green, which is a thin layer of connective tissue containing blood vessels, nerves, and immune cells, followed by the muscularis mucosa in pink. And all the three, the epithelial layer, lamina propria, and the muscularis mucosa, form the mucosal layer. Moving further in, we can see the submucosal layer, which is blue in color. This is a thicker layer of connective tissue containing larger blood vessels than the mucosal layer, in addition to the nerves, lymphatics, and the mucous glands, followed by the muscle layer in brown color. And now let's assume that we are endoscopically managing a varix, and this varix is at the mucosal layer. Here, we will be able to fully suction the varix into the banding cap, ensuring that the band completely encloses the targeted varix, ensuring its complete obliteration, and this will minimize the risk of post-banding bleeding. In contrast, deeper vessels in the submucosa are more challenging to fully suction and enclose, especially the larger ones, as they will exceed the banding cap suction capacity, and this will lead to incomplete obliteration and potential risk of post-banding complications. So, we need to locate the areas where the veins are superficial or at the mucosal level, and identify if there are specific areas more prone to bleed than others. This way, we will be targeting varices at risk of bleeding so we can prophylactically manage them, and ensure that we deploy the band at the proper site, achieving complete eradication and reduce the risk of post-banding complications. But before we do this, let's take a moment to assess your current knowledge. I will be displaying some lesions, and I want you to decide whether you would proceed to endoscopic band ligation or not. Back to the session objectives, which is identifying the superficial varices locations and the areas more prone to bleed. To do this, we have to revisit the anatomy, specifically the venous drainage of the esophagus. The esophagus, as we all know, has a segmental blood supply where it is divided into three segments: cervical, thoracic, and abdominal esophagus, and each segment varies in its venous drainage. Again, excuse my drawing skills. Imagine that this is the superior vena cava, the left and right brachiocephalic veins, and the inferior thyroid veins. The cervical segment of the esophagus is drained by the inferior thyroid veins, which empty into the brachiocephalic veins and then back to the systemic circulation through the superior vena cava. Moving down to the thoracic esophagus, Again, this is the superior vena cava, and this is the azygous vein on the right side of the esophagus and the hemiazygous on the left side. So the azygous venous system drains the thoracic esophagus, which empties into the superior vena cava, in addition to the intercostal and bronchial veins that can contribute in its drainage, where they empty into the azygous venous system into the superior vena cava. Moving further down to the abdominal segment of the esophagus, which lies below the diaphragm, imagine that this is the portal vein, and we know that it receives blood from the splenic vein and the left gastric vein. The left gastric vein is responsible for the drainage of the distal part of the esophagus and the proximal stomach. These are the short gastric veins which drain the fundus of the stomach, and they empty into the splenic vein. And as you can see here, the normal blood flow direction is toward the liver in a direction called hepatopetal flow. But in case of liver disease causing portal hypertension, the flow is reversed to be away from the liver, known as hepatofugal flow. With this high portal venous pressure, the body attempts to bypass it by forming a collateral circulation, which we call portosystemic shunting, and this results in the formation of varices. The variceal formation requires a portal pressure gradient of at least 10 mm mercury, and a pressure of at least 12 mm mercury is thought to be needed for a varix to bleed. So to sum up, in portal hypertension, the reversal of the blood flow will cause a backflow into the left gastric vein, increasing the pressure in the esophageal veins, forming the esophageal varices, which can extend up to the proximal esophagus. And this backflow may also increase the splenic venous pressure, increasing the pressure in the short gastric veins, forming the cardiofundal varices. Okay, so now we are familiar with the venous drainage of the esophagus, proximal stomach, and how varices develop, but still we didn't answer the question: where can we apply band ligation? This brings us to a different approach for the venous drainage of the esophagus, where we won't only rely on the segmental division, but we will also divide it into 4 zones: gastric, palisade, perforating, and truncal zones. Starting with the gastric zone, this begins 2 to 3 centimeters below the gastroesophageal junction. And having a closer look, the distal region of the gastric zone have their veins lying within the submucosa, and they join, forming large tortuous trunks, while the proximal region of the gastric zone, there are numerous small diameter veins arranged in groups, and as we travel up towards the cardia, they become mucosal. And that's why it's hard to safely and effectively apply band ligation to the large tortuous submucosal varix in the cardiofundal area. However, band ligation may be applied to the lesser curvature varices near the cardia, as the veins here are at the mucosal level and of smaller diameter, so ensuring complete suction in the banding cap, achieving complete eradication. Moving up towards the cardia at the gastroesophageal junction, we now reach the palisade zone, where the veins become mucosal, and at this zone the veins are distributed uniformly in close proximity to each other, running in parallel and longitudinal as a palisade. In portal hypertension, the veins become engorged and bundle together, forming the esophageal varices cords. But take care that in this zone, there are no perforating veins, or what we call perforators. Just a reminder, the esophageal perforators are small veins that transverse the muscle layer of the esophagus, connecting the superficial venous network with the deep venous network, relieving the portal pressure. So here in this zone, we don't have the advantage of the pressure decompression, but the opposite happens. Here we will face a very high pressure that can't be relieved, making the varix in this zone with high liability to bleed. But luckily, it is at the mucosal level, so we can apply band ligation here to prevent or control bleeding with achievement of safe, complete obliteration. So band ligation can be applied safely and effectively in the palisade zone. Moving up to the perforating zone, which is 3 to 5 centimeters above the gastroesophageal junction, the veins again dive into the submucosa, making band ligation more challenging to achieve complete obliteration. But luckily, we have perforators in this zone, allowing pressure decompression. So the varices in this zone have a low probability of bleeding, and if you apply band ligation here, where the varix is at the submucosal level, there will be a higher risk of post-bending bleeding. And the same goes for the truncal zone, which is 8 to 10 centimeters, and the veins lie in the submucosa as well, and there is also perforators, so band ligation is not recommended here as well. And finally, the question is answered, and I guess it makes sense now why my mentors always recommended bending close to the gastroesophageal junction, as this is the palisade zone, which has the veins at the mucosal level, making it safe to fully suction into the banding cap, achieving complete eradication. In addition, there are no perforators in this zone, making varices here at a high risk of rupture. And now back to our cases. This varix is in the perforating zone with no extension to the palisade zone, so there is no need to apply band ligation. This is an esophageal nevus, so no intervention is needed. This varix is in the palisade zone, so yes, you can proceed to band ligation. And this is a fundal varix, so band ligation is not recommended here, and the management decision will be discussed in another video. Thank you. I hope you found this video useful. For more videos, please subscribe to my channel. Have a good day.